Good afternoon. Welcome to Congenital Heart Hour. I am Sophie Khan, one of the new consultants here, but Dr. Javanji normally hosts this meeting and he's been called away, so I'm stepping in for him. As he says every week, hopefully some of you have joined us before, but this meeting is about congenital heart disease and how we treat it and its impact. And he does like to try and keep a flavour of intervention and cardiac surgery as well. So sometimes the topics are controversial. And as you know, we have speakers from around the world and the UK. He does like to point out that we have people tuning in from around the world as well. So we have quite a big audience. So next week, before we come on to this week's talk, I'll just say that next week we have a speaker from Brazil. He's called João Abelão Sandoval, and he's going to talk from Brazil, but I don't know the topic, I'm afraid. I think Dr. Javanji is now joined and he can take over to introduce. Oh, okay. So Dr. Soda is one of our cardiologists that works in the Northwest and he's going to speak on aortopathy.
Thank you.
Thank you very much.
Thank you very much. Just click. Hi, good afternoon, everyone. I guess I was due this talk for a while and Salim did feel I ate too many pizzas already from this meeting. So I'm due to talk anyway. And thanks for the wonderful opportunity. As again, this is something quite close to me and we're trying to develop service around Northwest. Hopefully we'll get there to where we want to be next few years. This is a huge topic again, but however, we'll try to concise and try to give as much information as possible. Generally, once we talk about aortopathy, usually Marfan's is what brings to your mind first thing. But I think there are constellation of symptoms and signs which are there with associated lots of other aortopathies. Some of them are genetic, some of them inherited, some of them not, some of them even acquired, I dare say. So we'll go through a few things and try to demystify things a bit for all of you. So looking at the various syndromes, what we have, most of you guys are aware of Marfan's, probably know about Loeys-Dietz syndrome. There are a few other syndromes associated with aortopathies like vascular EDS. Some of them are more profoundly genetic, where we're picking up a few other mutations like 16p 11.13 microduplication, which is something quite recent we picked up, and quite a few of these children are associating themselves with aortic root dilatation as well. So we go through a few genetics, some of the basic cardiovascular anatomy, what we're looking for. Also look at the various imaging techniques we can use. Obviously, we're well versed with echo techniques measuring these aortic root dilatations. We know how important CTs and MRIs have become part of cardiovascular cross-sectional imaging. Medical therapy again is with something we're trying to evolve as we learn, as we go further. Physical activity and lifestyle changes is another aspect of cardiovascular rehabilitation, which we've been working on quite a lot. Obviously, we moved on from where we were saying nothing active should be performed in a person who's got significant cardiovascular disease, more so with somebody who's got aortopathies, which can potentially rupture. But I think we've coming out of those school of thought where we do try to encourage and ask them to be as active as possible. Of course, isometric exercises are the ones which are contraindicated. I'll go through a bit more about once we get to that topic. Surgical management. Hopefully, I'm not involved in surgery, but we all know how risky and how difficult these surgeries are, especially if there is an acute dissection. And we have, I'm sure, encountered in the last 1 year, 1 or 2 children coming in acutely with dissections, and we know how fatal that can be. So as I mentioned about the most common ones in Marfan's is quite well known. Loeys-Dietz, something which we picked up in 2005, 2006. 2 chaps, Loeys and Dietz, both from America. They do a lot of good work in Johns Hopkins. They've got about 300, 400 Loeys-Dietz syndromes over there, and they've done extensive research on this. This is again an evolving subspecialty of aortopathy. So far, I think we have identified about 4 or 5 genes associated with them, and we also trying to map them in terms of their pathogenicity, their penetrance. And more and more as we expand more of gene panels, we're trying to learn a bit more about them. Vascular EDS is another one which is quite often referred to us from our rheumatology colleagues. Usually they pick up with associated joint pains, or they suspect vascular ADS with evidence of any skin spray. Sometimes they've gone to some procedures for theaters and they've seen excessive fragility of blood vessels, and then that's sometimes prompted them a genetic referral, and they come up with vascular ADS. I think that's the gene in the brackets spelled wrong. It's COL3A1. It's collagen 3A1 gene, which is most pathognomic of vascular ADS. And we all know about Turner's aortopathies. Bicuspid aortic valve, again, is quite a common congenital anomaly, and we know that they do have aortopathies over a period of time. Arterial Torsades syndrome, something which again is quite sporadic, quite rare, but there's no genetic basis for these subjects to have this condition, but they do have lots of toxicities. It's associated with stenosis, can potentially cause ruptures as well. And as I mentioned about the new genetic condition 16p11.13 duplication, that's something quite new for the past 4 or 5 years. We found this recently. They have significant association with aortic root dilatation. And familial thoracic aortic dystrophies are something which are not syndromic, but we have associated genes with them. The rest of the major aortopathies like Marfan's, Loeys-Dietz, they're specific syndromic. They've got classic features of physical deformities, which we can identify with, but the FTADs are classified as some of the conditions where we have a genetic defect, but they don't have any significant phenotypic manifestation apart from aortic root abnormalities. So coming to the incidence of aortopathies, Marfan's clearly is the leader among all of them. But as I mentioned, there are other things which are coming into light. We have, I've taken the liberty of putting at iatrogenic acquired aortopathies, which we see in post-switch repairs. This is something, again, we're picking up off late, as you know, the switches haven't been in vogue for a long time. So any patient who had switches a third or fourth decade, we are seeing significant aortic root dilatations. These conditions, again, are more associated with aortic regurgitation. As such, the degree of dilatation isn't as pronounced as we see in other aortopathies. However, the degree of regurgitation in these conditions makes us probably a bit more jumpy on trying to prevent any further dilatation. I think I remember we had 3 months ago, we had a symposium on TGA-induced post-switch aortopathies, and none of us were quite keen to start any treatment at present, but I think we will reach some consensus at some point in near future. As of now, the measurements, what we get, at least in the children's age groups, what we see in our practice, about 35 to 40, just about borderline. For me, an alarming number is about 40 to 45 generally. If there is associated aortic regurgitation, anything 40 plus is significant. 45 plus is somewhere we just definitely need to intervene. This is not the medical treatment. I'm talking about more surgical intervention. Just going through history, we knew about Marfan's quite early, almost more than 100 years ago. Initially picked up with skeletal deformities. Some of them, again, presented with isolated lens dislocations. Even now, we get referrals from our ophthalmology colleagues who suggest that these kids come with lens dislocation. I'm not quite sure there's anything going on with him, because they see him about 4 or 5 years, or even 6, 8 years, and they've not got classic features of Marfan so early in life. And I have definitely had 3 or 4 referrals who've come to us with lens deformities, and I thought, yeah, this kid looks more Marfan. I'd be sent genetic referrals if they've come FBN1 positive, and clearly we knew the aortic root was dilated as well. So there are various modes of presentation. Loeys-Dietz was first picked up very early, again 1955, but completely formalized into a syndrome in 2005. And as I mentioned, the thoracic aortic dystrophies are something which is work in progress. Most of these syndromes are evolving, apart from probably the Marfan's, which I'm not seeing any more surprise as of now. But Loeys-Dietz, as I mentioned, we've got 5 types of syndrome as of now, but I'm sure we'll find a few more. One of the cornerstones of diagnosis is the revised Kent nosology. In an isolated patient without a family history, any sign of aortic root dilatation, Z score of more than 2 with ectopia lentis is diagnostic. Of course, if you have genetic mutation of FBN1 and aortic root dilatation, Z score more than +2, that's also diagnostic. We have few systemic criteria looking at other systemic signs, including various abnormalities of the chest, the lens, dural ectasia, the thumb signs, all this suggestive of joint and hypermobility syndromes which are associated with Marfan's. Once we add those criteria, the systemic scores more than 7, that's again a positive diagnosis with a positive family history. I'll talk a bit more about Z scores. I've never been a big fan of Z scores anyway for all age groups, but we'll go through a few things a bit later. These are the systemic signs I was mentioning about. Each sign has specific scoring, which is on the left of your screen. Most of them will have some of these associated symptoms and signs. Some of them are quite obvious, like your thumb sign and wrist sign are fairly easily picked up. So are the chest deformities. Pneumothorax are quite rare, although they come in with non-specific chest pain. Dural ectasia is something which we can't pick up unless we have an MRI. Sometimes, again, there are 2 or 3 instances where we had an MRI for spinal abnormalities and they found dural ectasia. We went back through, looked at investigations, and they turned out to be FPNN positive. So there are various ways of picking things up. And there are minor abnormalities like mitral valve prolapse, which is again a very common abnormality. Often I do get referrals with mitral valve prolapse. Can we look at this and see this child has got Marfan's? But that's a very soft sign in its own for a referral, really. So unless the children are at least meeting 3 or 4 of these criteria, I wouldn't generally jump and investigate them for Marfan's. More so if there's no family history. But you still have to remember that about 20% of Marfan's are de novo mutations. About 70 to 75% are inherited. It's an autosomal dominant condition, as we all know. Just to show the picture of what to look for in a wrist sign and a thumb sign. We all know what they are, but exactly how to demonstrate is just a picture which shows. And if you ask them to protrude the thumb through your palm, you should see the entire nail of the thumb should be projecting out. That's a positive thumb sign. I'm sure 1 of you or 2 of you will have it. I'll get an MRI on you and the gene test. Everybody's trying to do that. Salim definitely got it. And then, of course, the wrist sign as well. These are the 2 things which you can easily do in your clinic whenever you see them for giant hypermobility referrals. These are, again, some of the classic features, what you see on the chest. They can have pectus excavatum or carinatum. While we're on this topic, I do feel to mention that we do run a pectus service here. Lots of children, more so boys, actually come to us in the clinic and say they're quite concerned about the chest deformity, and they do feel we could do something for them. As we know, the NHS England doesn't support any surgical intervention. However, our pectus surgeons are more than happy to see them. So I would encourage anybody having issues with pectus, they're more than happy to be seen in the clinic. Ectopia lentis is again an ophthalmology sign, which one of our ophthalmology colleagues usually sends a referral for us. Most of the children with glasses with Marfan's is what you see because they would have had lensectomies at very early age. This is just a schematic representation of what I told about the systemic signs scoring, which we've gone through already. Coming to the pathogenesis, the nitty-gritty of the genetics, most of the areas we know are around the TGF beta 2, beta 1, and the fibrillin genes. FBN1 gene is involved in the Marfan's pathophysiology, while the TGF beta 1, beta 2 are more associated with Loeys-Dietz syndrome. The SMAD3 is another gene which you picked up, which is in turn named as Loeys-Dietz type 3. This is slightly benign, I would say, compared to LDS type 1 and type 2, because there's more of a skeletal involvement in this condition. So if you see an SMAD3 Loeys-Dietz, you can slightly be relaxed rather than jumping, thinking this kid's going to rupture anytime. These are the ones who usually present at 3rd or 4th decade. As I mentioned, we have a family of SMAD3 mutation, a family of 4. Mom presented first time after having a 3rd baby. So she's gone through 3 pregnancies without any problem. So they're generally relatively benign, and you don't see any catastrophic events in the early age group as we see in LDS type 1 and type 2. So the treatment again varies depending on what the genetics are. We're still not very aggressive in titrating our treatment based on the genetics. I think that's something we should look at in future as we get more and more information. Again, we're only into 10-15 years of Loeys-Dietz, so we got to be a bit careful generalizing before getting to any quick conclusions. This is again just a genetic slide to show where all the receptors are acting. There is essentially increased activity of TGF receptors, and that in turn causes more laxity of the vessel wall, and that in turn makes them more distensible. That in turn makes them more friable over a period of time. As you get a bit older, as the more distensibility goes up, the elasticity is lost, and they can get a bit more and more elastic, and over a period of time they get dilated. Eventually they rupture. That's the pathogenesis. But they're all concentrated on the area of TGF growth factors, TG and fibrillin, elastin, and these proteins which are involved in maintaining the integrity of tunica media of the arterial tree. As you know, there are three layers: tunica, media, intima. The media is the one which plays a major role in distensibility. This is genetics slide. I wouldn't worry too much about this. It's just more when you talk on genetics, you go on to these things. Let me skip that too. So this is the, in a nutshell, overall the genetics involved in all of these aortopathies. The most common ones, as you see on the right side of the panel, the TGFs, the SMADs, and the common one which have a constellation is an FBN one, which pretty much got involved in everything really. And the most worrying for me is the collagen 3A, where we do see quite early mortality and morbidity in these ones, because the vessels affected are all over the body, essentially abdomen, uterus, all over the place. And I've certainly had two children who were about 13, 14 who presented with sudden rupture and they passed away. There's nothing we could do for these children. So collagen 3A mutation is the one which probably is most pathogenic and most dangerous of the lot. And sadly enough, there's no indication for us to actually put them on any medications, because there's no root dilatation. There's no evidence to suggest any medications would actually prevent the rupture as well. So it's one of those conditions where you don't want to see them in the clinic, and you can't stratify these children. Looking at the autosomal dominant pattern, this is something which Kate is quite familiar with, drawing the family tree. And most of the aortopathies are autosomal dominant, including Loeys-Dietz and Marfan's. And there's a 50% chance of children getting affected. And as I mentioned about mutations, 20 to 25% are de novo mutations, most 70 to 75 are inherited. So roughly about 20-25% of our children are presenting with de novo mutations. We've gone through the signs and symptoms of various organs involved. As I mentioned, these are all multiple organ involvement, including the heart and the joints, the spine, any areas where you have elastin tissues, those areas are affected. That's again reflects on your lens being dislocated, your joints being dislocated, your vessels in the arteries more distensible. This is a new entity I wanted to share about. I think we've kind of noticing this slightly later stage of life. There is a new entity called Marfan's cardiomyopathy, which has been put through to us for the past 8-10 years. I think there is evidence of slight LV dysfunction with progressive cardiac failure over a period of time. We do see cardiac failure in fairly commonly in the newborn neonatal Marfan's or early Marfan's because of significant mitral valve regurgitation, and that ends up with severe AV valve regurgitation, cardiac failure. But this entity is more myocardial dysfunction over a period of time, seen in 4th or 5th decade of life. Again, a constellation of various factors, including the genetics, including the degree of regurgitation we see in the aortic wall progressively, which increase LV pressures, which increase the LV and diastolic volumes, and long-term myocardial damage. So again, there is a conundrum of whether we need to treat these ones with aggressive beta blockers or not. I'll come to that a bit later in terms of what's appropriate treatment for these patients. Luckily, we don't see a lot in children, so it's more an adult entity, apart from the neonatal Marfan's, where they end up with cardiac failure secondary to severe mitral valve regurgitation. So this is again a nutshell of all the syndromes who are very much interconnected. Everything is connective tissue related. Everything is related to 3 or 4 proteins, the fibrillins, the elastins, the TGF growth factors. And again, the joint laxity causes all these symptoms, including pneumothorax, your inguinal hernias, joint hypermobility, scoliosis. And again, that also affects the internal organs, including your vasculature. Looking at main workups of what we need to look at if you encounter Marfan's for the first time, as a cardiologist, obviously you would go through your echocardiogram, have a thorough investigation in terms of what the associated lesions are with mitral valve prolapse or aortic root dilatation, aortic root measurements. An ophthalmology referral is almost mandatory. You would send them for a slit lamp examination to look for any evidence of lens dislocations. Skeletal studies, I wouldn't be jumping on them getting any skeletal studies straight away. If there is any evidence of kyphosis scoliosis early, I would get a chest X-ray just to see the spinal curvature, because often we tend to refer to spinal surgeons much later, and the surgeons do not really get a feel of how things have progressed. It's always good to have one baseline spinal X-ray, very early part of seeing them. Usually our genetic colleagues do this for us. And again, magnetic resonance is something which we would look for at later stage of life. Dural ectasia is something which is an incidental finding, we pick it up, but MRI for cardiac root dilatation is something which is quite common as we get transition towards adult side. Prenatal testing has been offered to a lot of our patients, and some of them do take it up. Genetic testing is obviously, the expenses don't come into picture in NHS, but in America and other places, the panels are quite expensive. Some of them cost about $800,000. I've seen my colleagues across the Atlantic saying they would rather make a clinical diagnosis than go through these things prenatally. So it's all ruled by economics, really. There's another slide showing about what the different manifestations of each conditions I've already gone through. The last bit is what I would like to look at. These are the ones I mentioned about familial thoracic aortic dystrophies. These are the ones which have been identified with various gene deformities, although they don't necessarily have any other systemic symptoms. And these still need to be followed up. I must say these are quite rare and constitute probably less than 1% of what I see. Coming to a bit more about Loeys-Dietz syndrome, this is definitely more aggressive aortopathy compared to the most of the other ones. I've mentioned about the genetic variants. LDS type 1, type 2 are the more aggressive ones. They are the ones who need more aggressive management. The thresholds of us intervening in these ones is much higher in terms of the aortic root dilatation. We have any aortic root measurements about 40 is where we would like to intervene in them. They have more associated anomalies, including craniosynostosis or osteoarthritis. Facial features are quite classical: hypertelorism, strabismus, cleft palate, and bifidobula. These are the classic ones which we see on the facial features. Some of them have extreme spinal abnormalities. It becomes a catch-22 situation with these ones where you have really bad spinal abnormalities, significant spinal curvature problems. That again precludes them having any aggressive cardiac surgery. We certainly have 1 or 2 patients who had severe spinal problems who get in trouble with breathlessness. They need non-invasive ventilation, and we can see progressive aortic root dilatation. So it's almost like the spinal surgeons don't want to touch these patients because of significant cardiac morbidities, and our cardiac anesthetists are not keen because of their poor lung volumes. So ideally, we would like to avoid this situation as we probably monitor them more aggressively and make early referrals to manage them. And pectus abnormalities, certainly refer to pectus surgeons as soon as possible. So this is a nutshell of what we know as of now with Loeys-Dietz syndromes. First 2 other ones you got to be a bit more careful. The rest of them are slightly benign in the sense they generally tend to manifest much later. The second, third, fourth, and fifth are the ones I probably will be more cautious in starting ARB or beta blockers very early in life. We all know as of now, there are about 1,000 Loeys-Dietz picked up all across all over the world, and most of the type 3, 4, and 5, we don't see early manifestations of them. However, it still doesn't exclude from us having cerebral imaging and other extravascular imaging apart from just the cardiac imaging for them. General tendencies about have vascular imaging every 2 years in them. Mostly it's an MR angiogram. Okay, similar slide. This is a vascular ADS I'm mentioning about. This is probably one which, as I mentioned, we struggle most. They present with easy bruising. They can have quite thin translucent skin. Surgeons have gone in for some minor procedures. They see excessive bleeding, unable to heal the surgical lesions quickly, and some of them can present with abdominal vessel ruptures. We had a 13-year-old girl recently, about 2 years ago, presented to A&E with abdominal rupture, and she just died in front of our eyes. We couldn't do anything to her, and we knew what the diagnosis was, we knew what the pathology was, but we just couldn't do anything to her. So these are the ones which we really cannot do anything, and there's no risk stratification whatsoever. But if you have collagen 3A1 gene positive, that's the ones who are at highest risk of spontaneous rupture of uterine vessels, spontaneous rupture of intestinal vessels. Pregnancy again is a big risk for them, and there's enough evidence that most of the morbidities and mortalities happen during pregnancies. The rest of the EDS, you wouldn't worry too much. The rest of the non-vascular EDS, we do get referred quite a few of joint hypermobility. That doesn't necessarily mean they have a cardiac pathology. So I would be very careful in accepting these referrals unless there is evidence of vascular EDS in them for us to look for the cardiovascular abnormalities. They might have an odd mild mitral valve prolapse, but that's again one of the most common congenital anomalies we see. So I wouldn't necessarily need to go through a thorough aortic root imaging in rest of the EDS, except it being picked up to be vascular EDS. So this is something which our rheumatology colleagues always score on. It's called the Baton score, to look for evidence of EDS, unless, again, as I mentioned, without all these features, they have evidence of collagen 3A positive. I wouldn't necessarily take it as a positive referral for us. There is a tendency of overlapping of symptoms, as you can see in vascular EDS, where they have skin laxity, varicose veins, and a bit of joint laxity. I'm still quite skeptical about I should be seeing all the EDS as a part of aortopathy, really. So this is just what I mentioned just now about vascular EDS, this slide I just spoke about. This is another syndrome which is quite classic and similar to Loeys-Dietz syndrome. If you see in children with Loeys-Dietz, it's almost impossible to distinguish between Swinton-Goldberg syndrome and Loeys-Dietz syndrome. They've got very similar facial features, but they're quite mild in terms of aortic root dilatations. This is more a genetic review rather than more intense cardiovascular review. These children are generally much more easy to manage. I've never seen anybody getting to surgical thresholds in this condition. I've got 3 or 4 of these, but none of them needed any significant intervention as of now. Coming to some of the common characteristics, what we see in most of the aortopathies, all of them have a phenotypic variation, except Marfan's, I would say, because that's the only gene we have identified so far is the FBN1 gene mutation, although there is de novo mutation or inherited mutation. They all have high degree of penetrance, which means they're all autosomal dominant, all get progressive over a period of time, some of them quite rapidly, some of them over 3 or 4 decades, like your LDS type 3, type 4, and type 5. The neonatal Marfan's, again, is the most aggressive form of all the aortopathies, and there is almost 50% mortality in them unless they get through the first year of life. Usually the cause of death is a severe mitral valve regurgitation, which again is almost unrepairable, and surgeons often are reluctant to do a mitral valve replacement in these ones just because of the tissue fragility they have, and usually a mitral valve replacement doesn't really hold on that well in these children. And again, most of them have preventable adverse outcomes. The idea is to prevent as much as possible, try to spot them early, try to be aggressive in management, and hopefully intervene at the right time. And these are syndromes I mentioned, which are non-syndromic, although you call them syndrome, but they're non-syndromic. They don't have any associated other physical characteristics except the genes which they're associated with, and they constitute about 5 to 10% of all the aortopathies. This is something which we commonly see in bicuspid aortic valve, and I think as I started training more and more into my cardiac training, we started to see them more often. I clearly remember when probably 10 or 15 years ago, we wouldn't be following them up that frequently, probably send them away and then you'll be fine. Most of them have this condition, but we know over a period of time there is some degree of aortopathy in them, and there is progressive aortic root dilatation. The root dilatation in them is more of an ascending aorta rather than the aortic sinus or aortic root measurement. So the thresholds again of intervention is slightly different compared to your Marfan's. Generally, the numbers for aortic root involvement or intervention is about 55 millimeters, probably the highest of all the other aortopathies. This usually happens probably 4th or 5th decade than any of the other aortopathies, which happens much earlier. This is just an image to show what the dilatation of your aortic root looks in a bicuspid aortic valve. As you see, the dilatation is more at the level of the ascending aorta rather than at the level of the sinuses, which is what we see in most of the other inherited aortopathies. Already spoke about the TG aortopathies. I think the key factor, one of the reasons the pathogenesis why we picked up on this is the way the switch operation is performed. It does cause some degree of tissue laxity in them, and there is progressive dilatation. From what I have seen in children with this condition, you definitely see an aortic root dilation fairly early, and then that progresses over a period of time, but not as aggressive as other aortopathies. However, there's always an associated aortic valve regurgitation. In these conditions, you almost certainly see some degree of new aortic valve regurgitation post-switch, and that's what probably makes this slightly more aggressive in terms of needing an intervention at some point. However, I don't think we've ever offered any aortic root surgeries in any children before 18. I've speaking to a few adult congenital colleagues, they're looking at about third or fourth decade where they need to come to some degree of intervention. Again, we still haven't agreed on any management in terms of starting ARBs or beta blockers in them. Looking at general investigations, what we see in all the aortopathies, it's fairly obvious in terms of getting an echo done or a CT or an MRI. Lots of controversy about Z scores, which we probably have almost in every meeting. The non-cardiac complications have to be looked after by a general pediatrician. Usually our genetic colleagues are quite good in managing all these conditions. They may ensure that all the referrals have gone to the right people. An ophthalmologist, a spinal surgeon, a pector surgeon, sometimes a cardiologist, a skeletal or orthopedic surgeon, and the genetics. These are the people you like to be associated with children with aortopathies. Sports and lifestyle, again, things have evolved over a period of time. We've definitely moved on in terms of restricting them with their activities. We definitely encourage them to do a lot more than what we used to do about 10 or 15 years ago. Role of medical management, again, that's an evolving process. We've recently known about losartans and other ARBs, which have been much more effective than your traditional beta blockers. Again, intervention in terms of surgical or even intervention over a period of time is an evolving process. We rarely see aortic root surgeries happening in children with aortopathies in our age group, at least till 16 or 18. We tend to push them towards the adult side as much as possible. But some of them, if they're really aggressive aortopathies, we have intervened them in the first decade as well. In terms of managing the investigation, the finances, generally, obviously, the echocardiogram is probably the cheapest and the most easily accessible. CT has its own pros and cons involving radiation, but relatively easily done, while your MRI is definitely much safer, but more expensive. Some of them need general anesthesia. The timing of interventions, timing of investigation, especially the cross-sectional imaging, is probably once in 2 or 3 years. The lowest date syndromes are the ones which you probably need to have religious intervention in the investigations every 2 years. CT angiogram is generally the preferred mode of investigation for any aortic root replacement pre-op workup. Just look at the coronaries, just look at more detailed in terms of how the aortic root dilatations have evolved. And this is just a general schematic representation of all the relevant measurements you would like to do in an echocardiogram. I think all these measurements can be easily done. I tend to definitely try as much as possible and get all the measurement what I show in this picture and have a serialized measurements every year. We often tend to think it's the aortic root and sinuses which can cause problems, but we have seen the aortic dilatation dissection can happen further down the thoracic aorta, and we can probably map entire thoracic aorta, including abdominal aorta as well. So we should be able to picture out all the measurements I've shown in this. Maybe something beyond iliac is not something easily done with an echocardiogram, but up to renals and mesenteric arteries, we should be able to measure the entire aortic root dimensions. Looking at in terms of the standardization of echocardiograms, again, every Z scores are different. As we all know, the body surface area measurements itself are quite different. Each formula gives your body its different body surface area. That itself puts in so many variables in. So I'm traditionally not a big fan of absolute Z scores. I would rather still look at what's the rate of change of aortic root each year or every 6 months. If the child is getting more towards puberty, I would like to see them every 6 months for the next 2-3 years. If I see the aortic root dilatation is progressing more than 0.3 centimeters every 6 months, that's a worry for me. If it's going more than 0.5 centimeters per year, that's definitely a worry for me. So these are things you would look for in terms of aortic root progression. There is another parameter some of the centers use, which is aortic cross-sectional area divided by height of the patient. Height is in meters, aortic cross-sectional area is in centimeters square. That if that measurement is more than 10, they consider that as significant. Again, this needs a cross-sectional imaging in terms of an MRI or a CT. So echo is still definitely the cornerstone of measurement. And if I see a progressive increase in the measurement, that's usually an alarm sign for me. Just to show a picture of where we can measure and how we can go wrong in measuring. There are measurements which suggest inner edge to inner edge or leading edge to leading edge. Each measurements can differ and give a reading about 2 or 3 millimeters that way, this way. And if your Z scores can easily become +3 to +4, +4.5. So that's the reason I don't generally tend to put too much weighted on Z scores. This is just a schematic representation of where you want to measure, of different measurements you want to take. You would like to look at the aortic root annulus. I would tend to measure the hinge points in systole for the aortic valve, while the sinuses ST junction ascending aorta are measured in diastole. Some of them do have an eccentric dilatation of the aortic root. Certain sinuses are eccentrically dilated, so it might not be easy to get the most accurate measurement. However, the largest diameter is what I would still look for in getting a measurement. And we do differ getting measurements in a CT or an MRI compared to the modality in echocardiogram. At ±2 millimeters, I won't really worry too much. But overall, if the trend is going towards more than 0.5 centimeters per year or 0.3 every 6 months, that's something I would worry about. This is just what I mentioned just about. Am I okay with the time, Salim? Hope I'm not.
About 7 minutes.
Okay, fine. Thank you. So just going through some of the pictures of measurements. So this is how you will be looking at measuring the aortic roots in cross-sectional imaging. Some of the centers measure cusp to commissure measurements. Some of the centers use the sinus to sinus measurement. And this the bottom right picture is the one where you measure the cross-sectional area of the aortic root. And serial measurements always more helpful. Again, if we don't do biplanar or multiplanar imaging, it's easy to miss the actual measurements. And again, if you see in this picture, the ascending aortic root is much more dilated than your sinus Valsalva. And this clearly is a case of a bicuspid valve, what I mentioned over there. This is again a correlation of CT versus echocardiography. The measurements, what we see in the middle picture is the one from an echocardiogram that's measured in diastole, while your CT measurements, it's a cusp to commissure measurement or a sinus to sinus measurement, can vary in the measurements. So the maximum diameter is what always I would give most value to. Again, looking at the multiplanar imaging, as you see, if we don't measure in the right plane, you can get completely different measurements. If you measure in the wrong plane, if you see the bottom left picture, the diameter is completely different compared to the one on the right. So it has to be a biplane measurement in a CT. So whenever we're measuring even vessels, just make sure you're measuring biplane measurements, be it aortic vessels or even the size of the pulmonary arteries. Always use a biplanar measurement to get more accurate measurements in size of measuring the arteries. Again, looking at the Marfan's and lowest use, the pathogenesis, as I mentioned, is quite different. So there is increased dilatation. The degree of dilatation is much more extensive, much more progressive. The cranial vessels are quite often involved in lowest deeds. So the imaging modality, although is still the same, you have to do cranial imaging, cranial arterial imaging in a lowest deed syndrome. I would generally ask them to do an MRI angiogram, including head and neck vessels, up to the iliac vessels. That's usually once in 2 years. Again, the kids need GA, so you got to be a bit reasonable in requesting these investigations. And again, cardiac MRI sometimes is useful looking at the regurgitation fraction and the ventricular function. In terms of pure aortic root measurements and dilatations, probably CT is still the preferred mode, although radiation does preclude the number of times you can use it. 4D imaging is something which is coming into picture. We've kind trying to picturize which way the blood flows and the track the RBCs and which part of the areas of the aortic roots they're trying to hit and cause more dilatation. There's more potential to work on this, and we can predict the degree of damage of aortic distensibility over a period of this. Something work in progress still. I think we'll probably hear a bit more in cross-sectional imaging in future. There's a picture just to show a dissection can happen anywhere. There's a Loeys-Dietz syndrome child who had a dissection just above the renal vessels. So the importance of imaging as much as possible when you see the child in the clinic is cannot be overstated. This is a clear case of dissection which starts all the way from the aortic root and heads all the way through the descending aorta. And this is the cross-sectional imaging of it on the right side of the panel, showing the false lumen and the true lumen. You can easily distinguish the false lumen and true lumen based on the pulsatility, based on the diastolic and systolic motion of the true lumen and the false lumen. MRI also helps to look for the extracardiac signs, including the dural ectasia, spinal problems, pneumothoracis. Pregnancy is something I would like to mention, as most of the conditions, aortopathies, are quite high risk, and there is evidence of them manifesting with significant morbidities during pregnancy and post-pregnancy. Postpartum period is something which is quite often associated with aortic root rupture than intrapartum, because there is evidence to suggest that oxytocin release, oxytocin secretion can cause problems with aortic root dilatation. So therapeutic options, if we know the common medications, what we use, the angiotensin receptor blockers are the ones which are quite commonly used. I tend to prefer the more aggressive aortopathies are managed with losartan. Some of them do not tolerate them very well. The various studies which work against ARBs, which some of them have suggested ARBs are much more better in terms of managing the relative dilatation of the aortic root, while the beta blockers still have some say in preventing the rate of dilatation. Beta blockers obviously are limited if the child is having VZFs or asthmatic. We're limited with those. There's several studies which have showed that ARB is definitely much more effective than a beta blocker. In terms of management, do we really need to give any medication if the aorta is normal, the dimensions are normals? I sometimes leave the choice to the parents. You also look at the history of the similar gene expression in the rest of the family members. If there's an early aortic root rupture or early dilatation, early intervention in the families, that something counts more in favor of managing them early than you trying to intervene before you see any change in aortic root dilatation. As I said, be more aggressive in more aggressive aortopathies like LDS type 1 and type 2. Some of the beta blockers can cause adverse effects in terms of hypotension, low blood pressure. Some do not tolerate them very well in those children. Generally, a low dose would be quite ideal. The recommendations generally are you can give as much dose as possible as a child tolerates. I would go up to 2 milligrams per kilo on a beta blocker, and ARB is about 1.4 milligrams per kilo once daily. Most of them are once daily dose and easy to administrate as well. Again, this is something which just shows quickly how the aortic root size changes and the risk of aortic dissection changes as the rate of increase progresses. So anything about 4-ish is where I would worry about. Up to 3.5, we still manage reasonably well. Anything 4+, especially they get in teenage years, I would be more alarmed. I would probably do a cross-sectional imaging and at least have one discussion with surgeons about the time of intervention, especially if there's an early rupture or dissection in the families. Right. Okay. I think let me wind off. I think we've had probably enough of aortopathies at the moment. Just because we're running out of time, I might just give some time for some questions as well.
Thank you, Giri, for a fantastic talk. Very informative. You can have a seat here. Does anyone have any questions?
So thinking of the long term of these patients, obviously some of the ones with the worst phenotypes, the worst genes, they potentially shouldn't get a carrier pregnancy. They would be advised not to do that, I would assume. So therefore, reimplantation genetics is not an option for them.
No.
So
No.
would they just be told that's it, 10 o'clock, you can never have children?
The problem is it's all about, at the end of the day, it's a patient choice. That's the problem. We can always advise them, but it's once I've spoken to a few gynecologists as well, and they do say we've been counseling them all along, but they just don't really comply with what we say, and they're fully aware of the risk factors. They're fully aware of potential problems. But again, as I say, the phenotypic variation penetration is dependent on what genetic variations we have. And I mentioned about Eloise mother, who's type 3, and she had 4 babies happily. So it all depends on what sort of progression the aortic root dilatation is, and we can risk stratify them based on how dilated they are, how much of a medical treatment they are in, and what's the chance of them having a significant rate of change of growth during pregnancy. I've seen mothers coming with their children who got 2 other children with Marfan's, and mom's happily moving around at 45, 50. She has aortic root of 45, and still, they come and tell me that, oh, they weren't really advised pregnancy, but I had 2 babies and they both are fine, although they're positive, but they both are fine. Well, we can't really, definitely say a definite no, really.
Because I know with like the channelopathy, some of them are told, obviously you can't carry pregnancy, it's too high risk. And then I've known some that have gone off and had paid for surrogate parents for pregnancy, but it seems to me that the logical option would actually be to have a surrogate if you're so high risk, rather than risk that. They want a family so much, it just seems quite harsh.
It is. And as I say, the lowest risk type 1, type 2 are the ones who we're seeing the average lifespan is about 25 years. The rest of the Marfan, they generally tend to live longer, and we know the conditions, we pick them up early and we manage them much better. And there are patients who had aortic root surgeries and they went on had pregnancies. It's all depends on what time we pick them up, how we manage them, and how we think is the risk stratification of them going through pregnancy.
And would they be advised towards the pre-implantation, or would they conceive naturally? And
Ideally, yes. It would be more that's probably a more logical way of managing them. But again, it's more about there is lack of liaison with us, the ACSD consultants and the gynecology team. I think that's where probably we should come to consensus and
so
give the right advice.
Every child in the Northwest, would they always be referred to you? Are you the one?
Yeah, for the ideally that's how it should be. And then I would generally say, if once they get into 16, we would always get them into the young person's clinic. Either one of you guys sit together and talk to them, and I would always encourage them to have a gynae consultation as well in future, so that this should be more I would probably say this is where your gynecologists come into picture. When they're about getting to teenagers, you should definitely sit with them, just like we counsel them, all children who are on warfarin, we do counsel them. So it comes under similar category, really. Ram.
Thank you for quite a vast presentation of the lots of genetic information to take home.
Sorry, I tried to squeeze everything in because
just for the therapeutic side, when they get into the aortic regurgitation, they start dilating quite quickly. So as I'm say, if they're on beta blocker as an add-on between ARB and ACI, if they're having progressive AR, are there any studies to confirm which one is better, or do you still go for ARB?
ARB is definitely much better. The problem with AR for me is it's more about waiting for the aortic annulus to be a reasonable size. About 22 to 25 is what the surgeons prefer. So if the aortic annulus is not that size, that means the child is much younger and the child is having regurgitation. We don't have a choice but to put up for surgical discussion. But trivial AR, I definitely can't tolerate. In fact, as I mentioned, we had a child who's about 9 years old, lowest it's type 1, quite progressive aortic root dilatation. But as the annulus got dilated more and more, his aortic regurgitation got much worse, and he's almost developed cardiac failure secondary to aortic regurgitation. Unfortunately, this child had severe kyphoscoliosis. Neither the spinal surgeons would do anything to him, nor the cardiac anesthetist would do anything to him. He's caught in that situation. That's what I was just mentioning about. We should be avoiding that situation. So if we see any sign of aortic valve regurgitation, that's a warning sign. Any progression, even to mild plus, I would definitely put him up for discussion, irrespective of how significant your Z scores are or how insignificant they are. Sophie.
Yeah, well, it's just two bits really. One is, when you were talking, I was thinking with all the multi-system involvement, Do you think there's scope for, because they're mostly screened, aren't they, waiting for a problem to happen? So would it be better to have like a one-shot clinic with spinal genetics ophthalmology for some of these kids, so you don't get to a situation where one's saying they're not suitable because of this and the other in their screening and working alongside people? And the other thing was, when you talked about transposition, I assume with the truncus patients, you have a similar thing where the valve can be regurgitating and then the aorta is prone to dilate, isn't it? In a similar way. So should they be under those same kind of thresholds? I haven't really heard of transposition aortopathy, but actually truncus aortopathy is a thing as well, isn't it?
I think the answering the first question, the multidisciplinary team has definitely been something which has been all over the world. It's just we're not geared up to the service what we provide. We almost try to we probably get some genetic input regularly, but having everybody together in one clinic is something I doubt the NHS will allow the resources for us to have. Yeah.
Because you're relying on genetics, pulling it all together, but then you might get in a situation for surgery where it would have been better to have the two specialties thinking about it. Maybe.
At least what we're trying to work is get more involvement from genetics when they sit together with us, definitely. And what I do is I'll copy in all these other specialties to make sure they're aware this child is waiting for you guys, this child to be seen, this child needs this intervention. But it should be really genetics who should be managing all these referrals. As I know, the most complex problems in these children is the heart eventually, yes. So we can try to manage that as much as possible, but trying to hold everybody together from the cardiology point is quite hard, is what I found. And in terms of the truncus and aortic root dilatation, the dilatation, what we see in a TGA is more related to the switch repair, and they see there's a lot of loss of the tunica media and the fibrillin material in a biopsy child post switch repair is almost similar to what we see in an aortopathy. So I think the dilatation is more because of actual procedure, how they switch the vessels. Truncus, I'm not quite sure.
PDA is another along the spectrum of aortopathies. So I thought with the truncus, you're probably not normal vessels either, but it's people to manage in clinic.
If you look at the physiology as well, anything which is regurgitant will have to dilate, isn't it? Like the pulmonary wall, you'll always see a pulmonary wall getting dilated in progressive fallows with significant regurgitation, and truncus wall intrinsically is not completely competent anyway. So any to and fro motion physiologically should make it definitely dilated, no question. But I think the TGA aortopathy is more related to the surgical intervention, what they do on the vessel, rather than the intrinsic mechanism of leak. And that's slightly different compared to your truncus regurgitation and the dilatation. But I've not seen the truncus progressing as much as what I've seen in the TGS, at least. Interesting to look at. I'll look it up and see what sort of measurements we get comparing both those.
Thank you very much, Giri. A very interesting discussion. I think we'll wind it up. Thank you, Giri, again for this fantastic talk. Next week, we've got Juan Pablo Sandoval from Brazil giving us a live talk. He's got 3 topics that he wants to talk about. He hasn't quite decided which one we're going to start off with next week. So I'll give you the topic when Jamie sends down the email. Thank you, iCardiology, for the sponsorship today. Please provide us with some feedback so we can just progress into the kind of talks that you guys want. Otherwise, thank you for joining and see you next week.
Thank you. Thank you, everyone.